Alrighty, so picking up where I left off yesterday, glaucoma is an increase in intraocular pressure. You have two different kinds, open angle and narrow angle. Um, it is impairment of the vision involving your peripheral vision, and depending on which one you have, open tends to be gradual, whereas narrow tends to be sudden, and they both have different pathophysiologies of how they occur, both of which are not apparently fully understood, I think. My understanding of open angle is the canals that help drain the aqueous humor have become blocked, as in arteriosclerosis, so like your veins less can get through it because it just keeps getting harder. That's how I see open. So those canals that's supposed to drain it are being blocked, so the drainage is going slower and it backs up the fluid. And it occurs slowly over time. Whereas narrow angle, the iris has become swollen somehow and is touching the cornea, which is preventing anything at all from coming through to drain. That swelling causes like a dam effect, so nothing's getting past. And therefore, you have a sudden increase of the aqueous humor causing pressure. That's how I look at it. Let's see. The drugs, you have miotics. Miotics constrict. It ends in a C, so constricts, miotic. Haha. You can have prostaglandins, which end in prost. Cholinergics, cholinesterates, carbonic anhydrase inhibitors. Your biggest one is acetazolamide, which mide makes me think of furosemide, so it has like a diuretic effect, helps drain the fluid. And then you have your midrasis, which are dilatings. D as a dilation. Their job is to dilate the pupil so that things can be seen easier. And then you can also numb the eye with propopcaine. Let's see, anything else? I already explained that. Okay, the next part is retinal detachment. So the way it was described to me that made sense to me is with retinal detachment, it's the opposite of glaucoma. So instead of having an increase in intraocular pressure, you have a decrease in intraocular pressure. That pressure is what helps keep the retina down and attached. So when you don't have as much pressure, it comes off. And then when it comes off, that's when you get the curtain effect. You can see flashes, but mainly it looks like somebody's drawing a curtain over your vision. And it's treated with sclera buckling, which puts not only the retinal back, but it also puts a little bubble in the eye to put the pressure down. And the reason, so if you don't have enough pressure on the retina to put it down, if you put that air bubble, gas bubble, oil bubble in there to help the retina, it's putting extra pressure on the retina to, keep it down. Makes sense to me. Let's see if there's anything else. Oh yeah, so if with this you want to keep the head in a dependent position. So dependent is going against gravity or with gravity. Against, I think. So you're going to be face down, and that's just to ensure that the bubble stays in the correct area. Then you got retinopathy. The two major causes is, like anything else, diabetes and hypertension. They can cause microaneurysms, which causes vessels to swell. And then you got vessels that reform. And those vessels that reform in the area are weaker and more subjected to rupturing again. And the main treatment is to control your glucose levels. You got macular degeneration. You got two types, I think. Yeah, you do got the two types, the dry form and the wet form. The dry form is a blockage. Wet form is there's fluid or blood or some other source of liquid-esque thing. Instead of you get vision loss, but with macular degeneration, it starts in your central vision. So if you were to look straight in front of you and there was, let's say, a red dot that's supposed to be like right in front of your eyes, you wouldn't be able to see that red dot unless if you moved your eyes to the side or turned your head to see it. And that's different from the glaucoma, because glaucoma is going from the peripherals. So if the red dot was in your peripheral, like where your shoulders were at, you wouldn't be able to see it. So you can't really see your shoulders in your peripheral anyway, but image. The way you can diagnose this is that with the Amsler grid, we should have discussed in the last chapter, but we can go over it again once I find the page. Alrighty. The sole purpose of the Amsler grid is, to detect macular degeneration. And what you do is you put a handheld cart that has black lines, that looks like graph paper. And it says the patient fixates on a center dot and records abnormalities on the grid line. So, not sure exactly how that works, but that is I guess if they were to stare at the dot, they would not see the grid properly. That's what I think. Alrighty, so the end with the eyes is you got preoperative and postoperative care. Preoperative, you want to give them stool softeners so they're not straining. You're going to have to give them numbing medication for the eye until they're ready. And the most important part is make sure you're applying it to the right eye that's going for surgery, so it's numbed and everything. And then post-operative, you want to try to prevent anything that would increase the intraocular pressure. So you're going to prevent vomiting, nausea, go ahead and get medication for that. They got to be careful with any strenuous activity, which includes sexual activity, until it's healed or when the doctor says they can go back in a couple of weeks. They have to bend over. Try not to bend over for long periods of time, not to lift heavy objects. And then next, we're off to the ear. You got your external otitis, which is inflammation of the external ear canal. And if it's going to affect your hearing, is it going to be conductive or sensory? Conductive, because it's dealing with the outside. It is also can be considered swimmer's ear, since that's the most common cause of external otitis. And an early sign, you're going to get pain, so the pain can cause an itching sensation, or a kid, if they have it, will want to pull down on their earlobe to try to, I guess, get the inside of it and relieve the pressure. Alrighty. And then you got otitis media, which is that going to be conductive or sensory hearing loss? I'll answer that in a minute. It is inflammation of the middle ear. So if it's the middle ear, it's going to be conductive. The most common cause for the otitis media is a upper respiratory tract infection. So that's where you get the saying, you got to sign it, an ear infection. That's usually where it's located. Your ears may feel full because of fluid or drainage, which is still fluid. You're going to have hearing impairment. You might have tinnitus. There's going to be pain. You can treat it with antimicrobials. If it's ruptured, you might have a tympanoplasty. If it's a kid that's having recurrent ear infections, they may get a myringotomy done, which is where they put tubes in the ear to help drain the fluid and prevent that pressure back up. You got labyrinthitis, which the labyrinth is in the vestibule. The vestibule is in the inner ear. So if it's in the inner ear, it's going to be sensory loss. And then also because it's in the inner ear, any inflammation or abnormalities in it is going to cause dizziness, vertigo, can throw off your equilibrium and balance. And if it's with a fluid or if it's caused by a fluid in the system, you can give something like an antihistamine or an anticholinergic, something that will, dry it all up and help remove the excess. Meniere's disease is not something that is well known. It's just known that it is a sudden, intense dizziness. I heard from somebody that when they get an attack, they have a specific medication they take to help lessen the symptoms. It doesn't go away, but it helps decrease the severity of it. And she said that if she doesn't take her medicine, she can land on her butt and everything. It's just so bad. And then you got preoperative and postoperative ear surgery. Preoperative, you just Got to make sure you have the right ear, the right patient. There's nothing in the ear. If it needs to be shaved, it's shaved. Clean it out. Post-operative is similar to eye surgery. You're going to try to prevent overstrenuous activity. The head needs to be supported. If there's any dizziness, the dizziness must pass before the patient walks. Hang on one second. After ear surgery, sneezing, coughing, and blowing your nose. Try to do it with your mouth open, and when blowing your nose, you do it one nostril at the time. Other things that you need to know: don't drink through a straw because of the pressure that it can cause. Limit your activity. Avoid hefty lifting. Keep your ear blocked and clean. Don't fly because that goes back into the pressure until the surgeon tells you can. Keep your ears protected from loud noise. Yep. And that is that. I've already answered the stuff in the back of the book, so now I can do questions from Evolve. Okay, I'm not able to for whatever reason, so since I finished the chapter, that's the end of that. Good day.